You never smoke, you never had the fossil fuel exposure, burning fossil fuel exposure, you were never in an industrial setting, you've had asthma, you've had this evidence of this remodeling of the airway, that some of the changes that you had mentioned, and at some point you show by lung function testing that you have obstructive airway disease. But you don't have those noxious stimuli and particles and gases that goes along with the definition of COPD that you mentioned. So is that COPD?
I'm not sure that's a true ACOS. ACOS has a higher mortality rate. It's a dangerous kind of condition. That's why we're not just, talking about two diseases. There's something really important here. And IL-6 really correlated with the cardiovascular mortality, which is really which drives the mortality in all these COPD-related illnesses.
What about the approach to treatment in the ACOS patient? Is there anything different about those patients in terms of your approach with respect to treatment?
I think implicit in the case definition is a component of asthma. And when we think of asthma, we think of airway inflammation for the most part. Is going to have some component of steroid sensitivity. So I would embrace the use of ICS and LABA, but probably we'll be starting anticholinergic, antimuscarinic receptor antagonists at the same time, treating both aspects, maximally bronchodilating while treating, at least with the standard cornerstone management of airway inflammation that we have with an ICS.
And being influenced by Ori and the Dutch hypothesis, I do on every COPD patient, in the CBC, I'll get an eosinophil, peripheral eosinophil count. I get an IgE on everyone.
I think emerging therapy is going to be very exciting in the next 5 to 10 years. What I see in my crystal ball is the use of biologics. We completed a study recently on the use of an anti-IL-5 therapy in COPD. And we found that we could improve the FEV1 by 150 mLs over and above triple therapy. And more importantly, in this phase 2 study, we showed that we decreased exacerbation rates. Now, it only occurred in those patients with peripheral eosinophils of greater than 200. So that suggests, as we deep phenotype our patients in the future, we're going to be using peripheral biomarkers, and those will predict response. And it's a team approach. There's no I in team. And the reason is really we depend on nurse educators. Typically, we depend on our respiratory therapists for rehabilitation. What the provider and the practitioner can do is correctly diagnose and prescribe. The job of the team is to get patients to adhere.
I think this whole discussion today, looking at COPD, asthma, and all of a sudden we have new phenotype, the ACOS, is really just the beginning.